We're all very delighted to welcome Andrew Parry here this evening to do a talk on congenital extrahepatic portosystemic shunts, which is based on extensive research that Andrew's been doing over many years with Rob White, and probably many of you have seen all of his different papers on this. But I saw this talk at ACVR and really wanted Andrew to do this to the whole group because it brings together an awful lot of different threads, and at the end kind of wraps them all up with some really, really cool theories as to why this is all happening. So Andrew, thank you so much for agreeing to do this at 8 o'clock in the evening after probably a very long day, and carry on. Thank you very much indeed.
Thank you very much, Vicky, for that very kind introduction. I've sort of fallen into all those ex-residents who've had to read a lot of the literature that I've been kind of spewing out on this over the years, because you may understand that it is, I guess it's more of a journey that we are walking down, and certainly some of the early papers that we published on this, I'm not entirely convinced they're quite as accurate as perhaps they could be in the light of more recent findings. So I'm just going to amble through the next sort of 50 minutes or so and present to you more the sort of journey that I have shared with Rob. For those of you who don't know, Rob White is Professor of Surgery at Nottingham. He's an extraordinary soft tissue surgeon, and many years ago, before I was even a vet actually, he was already looking at shunts and building up an enormous database and repertoire of both images and clinical experience. And one of the reasons that I sort of fell into this really was partly because he felt quite strongly that the imaging side of how we approach portosystemic shunts was really not good enough. It largely relied on ultrasonography and of course intraoperative mesenteric portography, which we'll come to a little bit later. So for the next sort of 50 minutes or so, this is what I'm going to cover. So we're going to talk a little bit about this left gastric vein, which we now understand is quite important for the production of the vast majority of extrahepatic portosystemic shunts that we see. I'm only going to be talking about extrahepatic portosystemic shunts. We're going to talk a bit about CT and intraoperative mesenteric portovenography to demonstrate the portal vasculature. The next paper we published was about shunts that involved the right gastric vein. And then we talked about splenic-cable shunts, these outliers, unusual shunts involving the left colic vein. At that stage, we moved on to try to look at the difference between CT and IOMP in patients with shunts. And we got to a point where we wondered whether we could just get rid of mesenteric portovenography altogether. And then the last bit, I'm just going to sort of tie it all together with my current feelings, our current feelings on this subject. And you'll see that, and I apologize for this, I'm probably going to ask you more questions than I'm going to answer for you. So why do we like CT? Well, it's pretty obvious really, isn't it? Everybody who uses CT, we get this extraordinary vascular detail. You don't need rocket science type CT scanners to produce this. This is our 10-year-old 16-slice scanner, which seems to be upgraded, but nonetheless, even the 10-year-old 16-slice, we're getting very beautiful vascular images. So we know that we can demonstrate portosystemic shunts in a large variety of ways. Ultrasound has been around for 30 years or more, looking at portosystemic shunts, and there are some people like Chris Lamb from the RVC who are extraordinarily good at this. But I guess that's one of the problems with ultrasound, is that it is rather operator dependent. And for surgeons, at least, they really want something that's transferable. They want to see the shunt themselves because it helps them understand the surgical procedure that they're going to undertake. Mesenteric portovenography has been around for an awful lot longer, 80 years or so. It's a very old-fashioned technique, but we still use it regularly, and it's certainly extremely useful partly because it gives us a lot of dynamic information, and we'll come to this a little bit later. So the problem with these varieties of modality for identifying shunts is that because they were largely operator dependent, it led to a very non-standardized description of how we describe shunts. And many shunts we would just describe as portoazygous or portocaval. And the purists would say, well, who cares? Because actually all we care about is how we're going to ligate this from the systemic circulation. So it doesn't really matter what we call them. And I suppose there's a lot of truth in that, but we are trying to push things forward and trying to pattern recognize. As radiologists, we're very good at pattern recognizing. So we really felt that it would be more useful to try and have a bit more of a systematic approach to this. So we started with our first paper, which was back in 2013, and we wanted to look at shunts that we felt emanated from the left gastric vein. And here on the right-hand side of the screen, you'll see that there's a kind of blow-up picture of the portal vascular anatomy, and you'll see that there are really 4 branches to the portal vein that we worry about. There's the craniomesenteric, the caudal mesenteric, the splenic, which has the left gastric, right gastric, and then the splenic branches. As far as we're concerned, as radiologists, these are ones that we are concerned about. And then we've got the gastroduodenal, which has the obviously craniopancreatic duodenal, but also this this right gastric loop just here. All these branches up here are the intrahepatic branches, which we're not going to be speaking about this evening. So why the left gastric? Well, because we just felt that when we reviewed the literature, this was the sort of shunts that involved this vessel. They were fairly regularly inaccurately described. So we set up this retrospective study, and I have to say a lot of the data for this came from Rob's rather extraordinary library. And we included patients that had a single shunt that we could see on mesenteric portography. We could confirm it on surgery, and in some patients, the later patients, we also had CT angiograms to see the shunt. And we managed to recruit 46 dogs and 27 cats, and of those patients, there were a substantial majority that had a relatively straightforward appearing shunt. So that was blood that passed up the main portal vein, left through the splenic vein, and then moved up through a dilated left gastric vein. The left gastric vein would then meet another vessel, the left phrenic vein, directly adjacent to the diaphragm. And at this point, it would turn very sharply medially, and then it would join the caudal vena cava. We found a variation of this, which was instead of joining the caudal vena cava, the morphology was extremely similar, but actually it joined the azygos. We didn't find any cats that had that variation, but we now know, and we knew at the time of several other authors who published this variation. And then we had 2 kind of variations in between where there wasn't quite such a straight, there wasn't quite such a bent appearance of the phrenic and left gastric veins. And then some patients that had this dilatation where the vessels joined the caudal vena cava. So here's a dorsal MPR, and here's our transverse images of one of these shunts. We'll just let these run a couple of times to get your eye in. The way I try to look at shunts is try and find the confluence of the craniocaudal mesenteric veins, which is about here. Follow the portal vein up. Here as the splenic vein came off, and then watch the rest of the portal vein before I then decide to look at the shunting vessel itself. So once again, craniocaudal mesenterics. Here's our portal vein, comes all the way up and into the liver. And you'll have noticed that coming off this side was a large splenic vein. And then that splenic vein also had a large tributary, which is the left gastric vein, runs up the lesser curvature of the stomach all the way up, then suddenly turns abruptly to join the left phrenic vein. We can see this more easily on the transverse images. Here's our splenic vein here, left gastric coming along here, along the lesser curvature of the stomach, then suddenly turns joins the left phrenic vein. So relatively common and thankfully reasonably straightforward shunt in terms of diagnosis. And you can probably see straight away, and I'm definitely preaching to the choir here, that as far as CT is concerned, we have this transferable imaging. So radiologists can have a dynamic conversation with surgeons, and surgeons really do understand. They can see, particularly on these dorsal images, they can see directly exactly what they're going to see in surgery. Here was the variation, and we'll see this a little bit quicker. So a large left gastric vein, and in this case, actually diving through the aortic hiatus, does a little wiggle, and then joins the azygous vein. So the patient looks like he has two aortas. Once again, here comes the left gastric vein, just here, all the way up along the lesser curvature of the stomach, but then now dives through the aortic hiatus. So we found that CT angiography was very useful in describing this particular type of shunt in more detail. We found that Shih Tzu seemed to be pretty heftily overrepresented, and for a while we just described this as the Shih Tzu shunt, which is obviously not entirely accurate. We also realized that the actual shunting portion, the anomalous vessel, it's actually quite small, and it joins an otherwise normal but dilated left gastric and phrenic or azygous vessel. So the portion between the normal vasculature, so on these volume rendered images, the portions between the normal left phrenic vein and the normal left gastric vein, the actual anomalous portion, is actually very small. And we had noticed that there are many authors beforehand that had described these great long shunting vessels, which just seems counterintuitive, that a dog will manufacture an anomalous vessel that's a great length. It seemed much more obvious based on this paper that perhaps the anomalous portion was the small part. We tried to address the sacral dilatation, and we weren't really sure why this was, but we noticed that with dogs with patent ductus venosus and intrahepatic shunts, they'll quite often have this this kind of sacral dilatation at the ampulla, so the communication of the left phrenic, left hepatic veins, and they're called vena cava in the center of the liver. So we wondered whether the alteration in the venous dynamics in these patients with left gastrophrenic shunts actually caused this kind of turbulence and had a similar effect. So after that, we realized that CT angiography was very useful, but we also realized that IOMP was really the mainstay of diagnosing shunts. And even more than that, it was really the mainstay of examining the portal system. So we wanted to just see how CT angiography was at looking at the normal portal vasculature and comparing it to IOMP. And there are plenty of papers from Allison, amongst many other people, who have looked at CT angiography for the normal portal venous anatomy, but nobody actually compared two modalities. Patients that had abnormal bile acid stimulation tests, so these are patients that we were expecting to have shunts. They had a CT angiogram which showed grossly normal anatomy. And then these patients would have then gone to theatre. They'll have had an IOMP, and they'll have had liver biopsies. So we had a small retrospective group of patients that had IOMP and CTA, but didn't have a macroscopic shunt. So these would be dogs that will have had primary portal hypoplasia or microvascular dysplasia. So we compared these to the normal anatomy text, and again, this is pretty intuitive. This is definitely not rocket science. We found that because CT, the contrast is delivered to the portal system pretty much all blood vessels at the same time, it stands to reason that we're going to get a much more useful, if you like, image of the entirety of the portal vascular tree, as opposed to just the vessel that we're injecting in the case of mesenteric portovenography, and then small portions of the extrahepatic portal system but actually quite a lot of detail on the intrahepatic portal system. So the next thing that we tackled was the right gastric vein, and I think of all the papers that we've published on this, there aren't that many. Feels like there've been a lot, but there aren't that many. This paper was the most difficult one for us to write. We had our cohort of patients, and we delivered a retrospective study with these patients. And again, we were looking at patients that have had a single extrahepatic portosystemic shunt, and we wanted to have seen them identified on surgery, and some of them had additionally had a CT angiogram. So again, it's a retrospective study, and with that, we all know the limitations of retrospective studies. This is kind of a close-up of the right gastric vein. So here's the main portal vein. Here's the splenic vein again, the left gastric vein that we've talked about already. And we know that the right gastric vein, which comes off the gastroduodenal trunk, so this is effectively a shunt that involves two branches of the portal vein. The right gastric vein comes in it, and at some stage, there's some sort of capillary anastomosis, so the left gastric vein, right gastric vein run very close to each other. So we found 24 dogs, but interestingly, no cats. So in our retrospective study, there were no cats. And we found 22 dogs had a pre-hepatic anastomosis to the caudal vena cava, and 2 dogs had post-hepatic anastomosis. And there was some variation, and this variation is a little bit complicated, and please bear with me, but probably the useful image on these is this one on the left, because I tried to skim out all the other stuff that we see on the other images, just to give you the important stuff. So with this type, which is the type A1, so it's a pre-hepatic caudal vena cava, so it joins the caudal vena cava at the epiploic foramen here, and it joins via the left gastric vein. So we have most of the blood shunting through the right gastric vein, joining the left gastric vein and entering the caudal vena cava. And that means in this particular subdivision of shunts, there's no communication between the splenic vein and the left gastric vein. So if you remember, in a normal patient, we have a splenic vein, and there's a tributary to the splenic vein, which is the left gastric vein. So that's not what we found with these patients. And here's a volume rendered image to show you the same thing. So here's our portal vein, splenic vein is a separate entity, and then here's our right gastric vein coming from the gastroduodenal trunk, right gastric vein coming across the stomach, down, joining the left gastric vein and joining the caudal vena cava. So that's variation 1. And here are some further images of variation 1. Here's a thick section reformatted dorsal view of the same thing. Variation 2, so still type A, and to be honest, I really wouldn't worry about A1, A2, and A3 and all that sort of thing, because as you'll see later, we've probably changed how we think about these things a little bit in light of further things that we've studied. But this one is kind of got the normal portal vasculature. So here's our main portal vein. Here's our splenic vein. It's got a left gastric vein attached to it, which is what we'd expect. If we carry up the main portal vein, it's got a gastroduodenal vein, it's got a right gastric vein. And once again, the right gastric vein joins the left gastric vein, but these two then join to form the anomalous vasculature into the caudal vena cava. And here's a nice volume rendered image showing the same thing. So splenic vein, left gastric vein joining the splenic vein, and then diving down to get this right gastric vein before joining the cava. Type 3, for these ones, we had a big right gastric vein again, joining the left gastric vein and dumping blood into the cava. But in these patients, we couldn't identify a splenic vein in the normal place. So there was no obvious splenic vein tributary joining the portal vein. So this is a really odd finding, because it suggests to us that the normal anatomy is manipulated. So there's not just a small anomalous vessel with these patients, there's actually missing vessels. And that, from an embryological perspective, is quite unusual and difficult to explain. And if it's unusual and difficult to explain, you worry that in retrospect, was that actually correct? Or is it simply that we just can't see these vessels, that they're there, but we can't see them because they're not appropriately contrast enhanced or they're particularly hyperplastic? And I'll come back to this point a little bit later. So here's an example of a type A3, and we'll just let this whisk through a couple of times. Caudal vena cava, portal vein here, go back down, here's our portal vein. So we'll just wait for this to turn round. So here's our portal vein, up it comes. We have the splenic veins not attached, so there's no splenic vein involved. Crosses across the right gastric, down through the left gastric, dumps blood into the cave. And you'll notice that the splenic vein, so the deep splenic veins, the veins draining the spleen, are joining this left gastric vein into the caudal vena cava. So there is no separate splenic vein, or at least there is no separate splenic vein that I can see. Again, I probably should say that doesn't mean there isn't one, it's just not one that we could find. We also had these two outliers, this very occasional shunt variety, and Rob provided the portovenograms for this. I didn't have a CT because it's an unusual case. And on these patients, we had a splenic vein, and it appeared that the right gastric vein joined the left gastric vein and then dumped into the cava, but this time the prehepatic cava. And it struck us at the time that it looked an awful lot similar to the position where blood enters the caudal vena cava for shunts that involve the phrenic vein, so the gastrophrenic shunts. And that was just a little bit curious and something to ponder as we move through this. So what did this paper teach us? Well, it showed us that most of the time mesenteric portovenography wasn't sufficient to categorize the shunts. We found that most shunts dumped blood via the epiploic foramen, so cable attachment at the epiploic foramen, so a prehepatic shunt. And that in all of the cases, the terminal portal tributary was actually the left gastric vein. So now we had two papers where we described a left gastrophrenic shunt, and shunts that we really were expecting to involve the right gastric vein had nothing to do with the left gastric vein, but we were finding that actually it was definitely the left gastric vein which was the terminal portal tributary. And this is quite curious if you think about it, because we've now got two different shunt types that we've described completely differently. Left gastrophrenic, and then this left, effectively a left gastrocaval with right gastric dilatation. And there is variation, and we don't know why. And we started to explore this kind of this theory about preferential flow. That is, blood will prefer to travel in one direction as opposed to another. And why would it choose to travel in one direction rather than another? Well, at this stage, we had no idea. But we knew that there was variation despite a consistent entrance point to the caudal vena cava in most patients. So if you looked at these different A1, A2, A3 right variations, they looked different despite having a consistent entrance point to the cava. If we explored this absence of valves, it would allow blood to flow in both directions through the left gastric vein and its tributaries. And that in itself is quite attractive because we can see that blood is not moving in the right direction. And there's a proposal that maybe there's different pressure gradients, the blood moving along the splenic vein as opposed to the left gastric vein, or rather, sorry, where the splenic vein is attached directly to the left gastric vein and where it isn't, where this sets up different pressure gradients, and that may account for different morphologies. We'll explore this in more detail. We then moved on to the main body of the literature. So this was our third paper. Sorry, this was our fourth paper. It was a retrospective study, same cohort of patients, but this time we teased out those patients that had a single extrahepatic shunt that directly associated the left gastric vein to the caudal vena cava, the epiploic foramen, without right gastric dilatation. And it was a big group, 98 dogs, 8 cats. And virtually all the shunts looked absolutely identical. So there was very, very little variation in the appearance of each shunt. And the vast majority of the portal vasculature, as you can see in this image, the vast majority of the portal vasculature looks completely normal. So we've got a normal extrahepatic portal vein. Here's the extrahepatic portal vein, the gastroduodenal trunk, the intrahepatic portal vasculature. It's normal, albeit somewhat dilated in places. So here's an example of, and you don't need to show you this, I'm sure you've all seen this before. Here's an example of a splenic shunt. They're relatively simple shunts. Again, we're following the portal vein up through the confluence of the craniocaudal mesenteric veins, and then we can see this splenic vein comes off pretty much straight away thereafter. Big dilated left gastric vein, which suddenly turns around and joins the left side of the caudal vena cava at this region that the surgeons like to describe as the epiploic frame. So we wanted to call this a left gastrocaval shunt when we published this, but we weren't allowed to because, well, partly because JSAP felt quite strongly that that would be very confusing, and I completely understand that, because we were now starting to describe several different shunts as left gastrocaval. So we wanted to call these so-called splenocaval shunts, but they didn't like that either. So we left it with splenocaval shunts, but probably if you're going to be anatomically accurate, we should describe shunts, and there's a paper by Payne et al. In 1982, if you want to look this up. We should describe shunts as the last portal vein that is left and the first systemic vein that is entered. So we should be calling these left gastrocaval shunts. So once we did that, we still had a handful of shunts that didn't obey the rules at all. So we had 6 dogs and 3 cats collected in the same way, retrospective, this cohort of patients. And these guys did not involve the left gastric vein or the splenic vein. They were uninterested in those vessels. They really liked the left colic vein. So all of these shunts involved the left colic. And they would join the caudal vena cava either directly or through a caudal tributary of the vena cava. And often this would be right in the pelvis. And on ultrasound, these are really hard to diagnose, because the cranial vessels, if you like, the vessels around the liver and the kidneys look normal, but you seem to have this large vessel right down in the pelvis, and you can see on these volume rendered images, the left colic vein is a long vessel, and the shunt is right down in the pelvis. So again, why do these things happen? Well, it must be that the blood is flowing in the wrong direction down the left colic vein. Blood should be going up the left colic vein, joining the portal vein into the liver. In these guys, blood is flowing the wrong direction down into the systemic circulation. And it makes sense, if there's a connection there, it's going to join the systemic circulation, because the systemic circulation is a lower pressure circuit, so blood will preferentially flow into it if there's a connection. But why is there a connection? Well, we knew that the cranial rectal vein drains into the portal circulation, but the middle and caudal rectal veins drain into the caudal vena cava, so the systemic circulation. We knew this from looking at the old papers, there's probably not many people that remember this anymore, but when we used to do scintigraphy in the very old days, we used to give rectal pateknotate and then try and diagnose shunts. Didn't do it for very long because it worked really badly, but we did notice in some of those patients that actually the pateknotate would become systemic, even though we were expecting it to stay in the portal circulation. And the reason for that is there's a little network of vessels that join the cranial, middle and caudal rectal veins. So if you like, there is already a portosystemic shunt there in normal patients. It's not a huge leap of faith to therefore imagine how that system can go wrong and you can have a macroscopic shunt there. So after we did this, I wanted to explore the more kind of purist radiology stuff a little bit more and look at CT angiography and mesenteric portovenography. So we'd looked at this, that we compared these in normal patients. Now we compared it in dogs that had a shunt. So we looked at a pre-op CT angiogram and a pre-ligation mesenteric portovenogram. And the reason was, we wondered whether we could just get rid of the pre-ligation mesenteric portogram. And that meant a shorter surgical time and less time with our patient open in surgery, and that's got to be a good thing. So we compared our patients, 49 dogs, 10 cats, that had both CTA and mesenteric portovenography, and we noticed that, well, both modalities showed the shunt perfectly okay. So they were both perfectly good at showing the shunt, but the CT angiography did a much better job at showing the extrahepatic normal portal vasculature, much better job than CT angiography. But then curiously, for the intrahepatic vasculature, we could see them pretty badly on both studies. But CT angiography did really badly where a patient had a shunt that involved right gastric dilatation. So where the right gastric vein was involved, so our A1s, our A2s, our A3s, and our Bs, CT angiography did particularly badly at demonstrating those. So didn't really understand why that would be. We understood why CT angiography and mesenteric portovenography wouldn't show the intrahepatic vasculature very well, because you can't get the contrast there in decent doses, because it would rather go into the systemic circulation because it's a lower pressure circuit. But why the right gastric in particular, the shunt dogs with right gastric shunts were different, was a bit unclear. So we postulated that maybe this had something to do with the portal venous flow dynamics, which are, if you read about it, they're extraordinarily complicated. In people, we know that tumours from certain parts of the gut will preferentially go to certain parts of the liver. And the reason that we think that's the case is because the portal blood is not uniformly distributed. It doesn't all mix together in a perfectly diffusely mixed pot. And so perhaps then, if we have abnormal plumbing, we have shunts that are causing right gastric dilatation, we're effectively streamlining blood to one part of the liver rather than the other. So we're getting towards the end of our papers now, you'd be pleased to know. We then wondered, well, if CT angiography does better than mesenteric portovenography at identifying shunts and looking at the extrahepatic vasculature, why don't we just get rid of mesenteric portovenography altogether? Surgeons hate doing it. It is a bit of a faff. And if we could just do CT angiography, then that would be great. But the only way we could prove that is by looking at CT angiograms preoperatively and comparing them to mesenteric portovenography after temporary ligation of the shunts. And this is something surgeons will regularly do just to make sure that they've got the right bit. So we did a small retrospective study with 14 dogs, 5 cats that had various different types of extrahepatic shunts. And we compared the preoperative CT angiograms to the post-ligation mesenteric portovenograms. And again, it's kind of intuitive. The intrahepatic portal vasculature is much easier to see on mesenteric portovenography than it is with CT angiography. And that's because after you've ligated your shunt, you've got a closed system gain, and you can push contrast into that portal system with the pressure on the syringe, which you just can't do with CT angiography. So CT angiography, again, it underperformed for the intrahepatic vasculature where patients had a right gastric shunt. And here's an example of a mesenteric portovenogram showing a patient that has right gastric dilatation, and you've got that beautiful intrahepatic portal vasculature tree that we could see on mesenteric portovenography. You couldn't really see that very nicely on CT angiography. So that was a similar finding to the pre-ligation. Again, maybe it's something to do with this portal streamlining. But the bottom line was, you definitely can't get rid of mesenteric portovenography. It's a dynamic process. Surgeons want to see where the contrast is going whilst they're doing it. They don't want to be referring back to a TV screen trying to work out what's going on. It has additional benefits. We can make sure the correct vessel is ligated. We can make sure that once one vessel is ligated, we don't open up a whole load of other shunts that we didn't realize were there. And if we do, we can do something about it. And as we've just described, you get a better idea of the intrahepatic portal vasculature. So Mesenteric portovenography is here to stay, and I think, to be honest, that's probably a good thing. So by now we had all these papers kind of flying around, a little bit confusing, and so we just kind of wanted to put things together a little bit. So once again, JSAP, who we are very grateful to for supporting us with the work that we've been doing, they allowed us to publish this kind of extended essay. And the essay was composed of two portions. It had a retrospective portion, and it effectively summarized the patients that we had already been looking at. So CT angiography, mesenteric portovenography, surgical observations of a single extrahepatic portosystemic shunt. And we were excluding our left colic ones. We were just looking at the ones that involve the left gastric vein. So that's the left gastrophrenics, the left gastroesophagus, that's paper 1, the shunts involving right gastric dilatation, and the so-called splenic-cable shunts. And we have 50 dogs, 10 cats. And we found that, and this was again slightly just summarizing what we already knew, the terminal vessel was always the left gastric vein, and that actually blood flows the wrong way through the left gastric vein in patients with a shunt. It doesn't flow towards the liver, as we'd expect, so down the left gastric vein into the splenic vein, up into the liver. It flows away from the liver, up the left gastric vein, into the phrenic vein, into the caudal vein cava. So if that's the case, then blood flow must be permissible in both directions. And that sounds pretty obvious, but took us quite a few years to get to that point. And as such, the left gastric vein, if you're going to allow blood flow in both directions, it means that the left gastric vein and its tributaries can't have valves, because valves by definition will only allow flow in one direction. Second part of our study, we looked at all the literature we could find involving portosystemic shunts, where the morphology was described in enough detail. A lot of these papers, they just didn't describe in sufficient detail what the morphology of the shunts themselves. And then we tried to put all this together, and I'm just going to try and show you this in this series of slides, which hopefully will, I guess I really hope it kind of brings it all together for you. So this is the normal portal vasculature. So the confluence craniocaudal mesenterics, portal vein, our splenic vein with our splenic root, our left gastric, and our right gastric, which is coming off the gastroduodenal trunk. Ignore the right gastroepiploic, right and left gastroepiploic are good veins, they never do anything naughty. And here's our craniopancreatic duodenal. So that's a normal blood vessel, normal flow as we'd expect. So blood is draining the gut, the spleen, and entering the portal vein and traveling in a hepatopetal direction. If we put a connection between the left gastric and the left phrenic vein, what happens is we change the flow. So flow now moves away from the liver towards the shunt. And because that happens, those little vessels are taking a lot more blood and they get bigger. If they get bigger, the other vessels are comparatively smaller, and then we get the appearance of the left gastrophrenic shunt that we're hopefully getting more familiar with. And that's what we see when we look at different modalities. So what about these left gastrophrenic with right dilatation, so the right gastric shunts, if you will. So once again, here is our normal portal flow. Here we're going to put a connection between the left gastric and the left phrenic. So this is exactly the same connection, but in these patients, the right gastric vein dilates rather than the splenic vein. And this is the sort of appearance we get. Now, we didn't have any cases that had this appearance, but we know of a number of other groups that have demonstrated this shunt variety. Next example. So this time, we're going to put our connection into our epiploic foramen. So these are all of our, in our paper, all of our left gastric shunts that had right gastric dilatation. So our A1s, our A2s, our A3s. Similar thing, here's our blood flow. Suddenly, that blood flow gets deviated Everything else gets smaller by comparison, and you're left with what we had, which is our type A2 shunt, which is what this looks like. So here we have exactly the same thing. Well, our splenocaval shunt, the most common shunt type, the connection's the same. It's exactly the same. It's between the left gastric and the caudal vena cava. But in these patients, instead of just having instead of having the right gastric vein involved, these just have our more conventional appearance with the splenic vein, the left gastric vein dilating. And this is the appearance that we have. But notice in these patients, we've now just demonstrated two consistent places where there's a shunt between the left gastric and the left phrenic, or between the left gastric and the cava itself. But we've got two or a range of different morphologies that result in that. There's got to be a reason for it. So lastly, left gastroesophagus. Instead of our left gastric joining the left phrenic or joining the caudal vena cava, it's joining the azygous vein. And same thing, here's the shunt that we get. So those are the variations that we have. There's one other variation, which is the same thing. So instead of coming up the splenic vein to the azygous, it's coming across the right gastric vein. Again, we haven't seen that variation, but we know other people that have. So we explored this kind of portal valves thing, and we wondered whether if there's a variation of portal valves, we can dictate flow. So if you put valves in one vessel and not another, then we can allow flow in one direction but not another. If we don't have valves in the vessel, we can allow flow in both directions. And this gives us a mechanism by which the distribution of valves might dictate which vessels can have flow in both directions. So then all we need is a connection between the left gastric vein and a systemic vein, which then causes an abnormal pressure gradient. We know the portal vascular, the portal system runs at a higher pressure than systemic venous system. And if that occurs in a vessel with no valves, we get a shunt. This allows us a situation where you can have a shunt. You can have a connection between the left gastric vein and the phrenic vein, for example. But if there are valves not allowing opposite flow, hepatopetal flow, you won't get a shunt. So that's we'll just explore that a bit more. So anyway, that new flow causes dilation of the normal collecting tributaries. And which portal vessel has valves will dictate which vessel can support a shunt. If only somebody had looked at portal vasculature and whether they have valves or not. Well, actually somebody has. So Dawson et al. 1988 did quite extensive research about this in people. And he found that fetal patients in people had portal valves, but often these valves would regress at birth. And even more than that, he found that the valves were pretty consistent in where they appeared, but they tended to appear close to the organ to which they're draining. So they'd be in the splenic vein, but they'd be close to the spleen. He didn't look at the left gastric vein, and he didn't look at several other veins. There are studies in adult dogs, but they don't look at the left gastric vein. There are no studies in puppies, and there are no studies in cats at all. So perhaps this is something we should look at. So we're suggesting, or we were suggesting, that presence or absence of portal tributary valves allows preferential flow through one vessel as opposed to another. And this is quite neat. So if we go back to our right gastric involving shunts, this is our type A2, the normal vasculature, if you will, so normal splenic connection to the left gastric vein, normal right gastric vein, albeit enlarged, and then left gastric vein dumping into the cava. Well, in this one, it's basically the same thing. It's just the blood flow is moving in a different direction. So it's just not involving the splenic vein at all. In this one, it's not involving the splenic vein at all, to the extent that we felt, and probably, to be honest, still feel, that the splenic vein, as we understand it, draining the spleen, the splenic vein, didn't actually exist as a separate portal tributary to the portal vein. So where does that leave us? Well, What we did know is that patofetal flow in valvulus portion of the system simply must exist. It must do, because otherwise, why do we get patients with multiple acquired portosystemic shunts? They are, by definition, shunts with blood moving in the wrong direction, moving away from the liver. So we must have portions, at least, of the portal system where there are no valves. And we found that in the four most common shunt types, so left gastrophrenic, with or without right gastric dilatation, the left gastrocaval or splenocaval, and the left gastric azygous shunts, it always involved the left gastric vein. And the shunts only seem to occur through vessels that were close to the left gastric vein embryologically. So the left phrenic, the involvement of the right gastric and the caudal vena cava, all of these things share extraordinarily complicated embryological origins. When we got to the literature review part of this paper, we just found that we had to exclude a lot of papers because they just didn't describe the shunt in sufficient detail. And of course, that's, as I said at the beginning, largely because ultrasound was used as a diagnostic modality. So where do we get from all of this? Well, it suggests to us that we should be able to predict portosystemic shunt type. We should also be able to classify our shunts, and we should also be able to classify shunts that haven't been reported yet, based on this idea of preferential flow. And if we can do that, it means that we should be able to facilitate surgeons, because there shouldn't be a huge amount of variation in these shunt types. Imagine a situation where we can say to a surgeon that this patient has a left gastrocaval shunt, and they can understand that with very little variation, they will know what they're going to find when they do the surgery. So just to wrap things up, in patients with an anomalous connection to left gastric vein and systemic vein, the presence or absence of portal venous valves may, if we can prove it, dictate what preferential flow is allowed to develop. And portal vasculature in shunts with patients with shunts is therefore largely normal. So there aren't great long portions of anomalous vessel. The anomalous portion is tiny in all cases. And patients with shunts only develop a finite number of shunts in a finite number of predictable sites. There are a number of shunt types that we know of that we haven't included, I haven't included in these papers. And this is, well, as you're probably getting the idea, this is still something that we're working on. So just to wrap things up, so the left gastric vein, it can go to the left phrenic vein, it can go directly to the caudal vena cava, and it can go to the azygous vein. If it goes to the left phrenic vein, it can have a left gastric dilatation, or it might not. So it either involves dilatation of the right gastric vein, or it doesn't, but essentially the plumbing, if you like, the connection between the left gastric vein and the cava is the same. The splenocaval or left gastric caval shunts is the same thing. So this shunt on the left is the same in terms of where it connects to the cava as these three shunts. These three shunts show a variation in right gastric dilatation, but effectively, the only thing that's different about them, we think, is the fact that blood is flowing preferentially differently, and perhaps that's because of distribution of vein valves. And then lastly, left gastric, we've never seen this shunt type, but we know it exists. Again, the connection between the left gastric vein and the azygous is consistent, but sometimes we have right gastric vein dilatation, sometimes more commonly we don't. So where do we go from here? Well, we've tried to classify these veins, and we've probably just caused more confusion. And again, I'm sorry if you were a resident and you had to go through all these papers and learn this. I do apologize. We will try and come up with something that is more useful, and something, therefore, that we can include other shunts in. But one of the things that we really want to know about is, does the portal system have valves? And if it does, is there variation in the valves that might allow a variation in flow of blood? So that concludes my presentation. Thank you so much for listening. I'd really like to thank Professor White, Rob White, who, as you can probably imagine, we've spent many an evening together over several bottles of wine trying to put this together. If anybody's got any questions, I'd be really happy to take them.
Thank you so much, Andrew. That was absolutely brilliant. Has anyone got any questions for Andrew? I'm just going to wait for them all to turn on their mics, Andrew. I've got some questions. Funnily enough, I've got some questions. I'm just really interested as to how you will investigate where the valves are, and is that like a dissection study? How big are these things? Can you see them?
Well, so that's several questions,
Sorry.
And the answer is I don't know yet. But if you ask me again in February, I may have a much better idea. So this is definitely a work in progress. We are working on using a number of cadavers, so fecal cadavers, and Rob is an extraordinarily exquisite surgeon. So what we're going to try and use is effectively do a CT angiogram on these little puppies, these stillborn pups, and try to see if we can see vein valves in these little patients. Whether we're capable of doing that or not, I don't know. We've tried to dissect out some of the portal veins to see if we can see the valves macroscopically without success so far. But I'm aware that there are some other research groups that are working on this and have had some limited success. So I'm not convinced that valves is the right answer, but there must be a mechanism by which these patients have completely the same connections between the portal circulation and the systemic circulation, but they have very different shunt morphologies. I guess the valve thing, it's tidy. If that's the case, it's very tidy. If we can make that work, but we haven't proved it, and I guess that's the next stage.
Cool. I've got lots more questions, but has anyone else got any others to add? I think everyone's gone a bit quiet. They might be.
I just want to add, yeah, the articles are quite a good reference. I always use them when I do a shunt report now, just with the nice drawing and stuff. It's quite nice, I must say. So it's my advice to everybody is to have them in hands every time you have a shunt case.
Thank you. That's very kind of you.
Hi, it's Ricardo. I have a question. What do you think about the small shunts that we find often incidentally, like gastrophrenic shunts? I think we see them like incidentally in dogs that don't have clinical signs.
Yeah, it's a really good question. I guess this could all fit again with this kind of preferential flow idea. And again, it's just an idea. And I know I've talked to you before, Manuel, about this kind of off the record, if you like. We definitely see some patients that have connections between the left gastric vein and the left phrenic vein in particular, but they don't seem to have an enormous amount of shunting blood. And we'll often identify them almost as an incidental finding. I know Manuel's seen quite a few of these. Why that should be, I'm not sure. You would think that if there's a connection there and there aren't valves, then there must be flow dynamics because you've got blood moving from a relatively high pressure system to a relatively low pressure system. You would expect that if the connection's there, there would be a large shunt fraction. But that doesn't seem to be the case. And I guess the answer to your question is we don't know yet, but we're working on it.
Okay, thanks.
Andrew, I got a question concerning, so you might have mentioned it at the beginning, yeah? But so amongst those cases that you describe, what is the proportion of cases that were non-clinically significant or had no clinical symptoms? And what is your opinion in those extra hepatic shunt that we sometimes see with no clinical symptoms?
Well, yeah, I mean, that kind of relates to Manuel's question. All of the patients that we saw in this retrospective study presented with clinical signs. So we have effectively introduced a selection bias in this study. because the only ones that we were investigating, the only ones that had CT angiography and portovenography, had clinical signs and associated biochemical markers raised by acid stimulation test. We have, I guess, if you like, a parallel group of patients that we seem to see shunts in, and they don't have clinical signs. And we haven't specifically examined those patients. I think it's something that we would really like to do. And I think increasingly, especially for the large number of teleradiology cases that you guys will be reading, we will see quite a number, not a substantial, but I guess a substantial minority of cases that we see shunts, and we're not expecting to see them. And where those fit in, I'm not entirely sure. But certainly in our papers, we effectively introduced a selection bias because all of our patients had clinical signs.
Yeah, thank you.
Any other questions? I've got one more just thought, Andrew. I don't know, do you think, and this is something that's going to be difficult to say because we don't know enough about the valves yet, but do you think there could be a sufficient pressure where valves could be overcome and shunt and flow could reverse? Or
well,
are they...
And that's quite neat, right? Because that would be a nice way of segregating those patients that have clinically significant shunts and the shunts that we see as incidental findings. Perhaps the ones as incidental findings, there's a little bit of flow, but actually the valves are doing the majority of the work. So they're allowing a little bit of flow in the wrong direction, but not a lot. Whereas those patients that have clinically significant findings or present with a clinical shunt, maybe those valves are overwhelmed. The only problem with that is if we get rid of the valve idea as to why some patients will have one shunt morphology as opposed to another, there's got to be another mechanism. And I guess for me, the first thing is it just seems quite neat to me that it could be these valves. But you know, as with all research, it's kind of a work in progress. If we find that the valves, they're just not, it's not the thing, it's something else, we're going to have to try and come up with a different model. So, I mean, to me, this is quite exciting, really, because, and I guess this is true for all research, really. You start with an idea, and actually you end up trying to answer a question that you didn't know existed to start with. And the fact that we're sort of generating this sort of discussion, I just find that really exciting.
Totally agree. I think it's super cool. I mean, the reason I really wanted Andrew to present this because I just really think this is an example where a massively careful, systematic approach and applying sort of real logic to such complex anatomy can come out with really important results. And I was so wowed with this idea of the valves at the end of it. I thought it was really cool. Has anyone else got anything else? Any other questions? If not, I shall say a massive thank you to Andrew for presenting this and tell him that we want him to come back again when he's done all these dissections, comment us and all these very tiny CTAs on these little puppies and let us know, because it's really interesting and I think it's totally changed my thinking on all of this. Thank you very much. We shall do a sort of virtual round of applause. Yep, there's lots of thank you, Andrew. Thank you very much, Andrew. I don't know if you can see them, Andrew, but they're all saying thank you.
Thank you very much, and thank you for inviting me. I really enjoyed it.
Cool, it's been brilliant. Thank you so much, and thank you to Virginie for organising this. Brilliant, and have an absolutely lovely Christmas, all of you. If we don't speak to you, I'm putting a camera on. Yeah, have a lovely Christmas. I hope you've all got things a bit more organised than we have. Cool. All right, take care. Have a good evening. Thanks, Andrew.
Bye.
Bye.
Cheers. Thank you.
Thank you. Bye.
Thanks, Virginie.